All right, let's jump right into this explainer. Today, we're unpacking the alarming scale of the prescription opioid crisis, and honestly, more importantly, the medical interventions designed to actually fight it. If you've been wanting to understand the root causes of this public health emergency and the evidence-based solutions that are literally working to resolve it, well, you're in exactly the right place.
First off, to really grasp the sheer magnitude of what we're dealing with, we have to talk about the economic weight of this issue. Get this. In 2007 alone, prescription opioid abuse cost insurers an estimated $72.5 billion. $72.5 billion. That is a staggering financial toll. To put that into perspective, we are talking about health and economic costs that are right on par with widespread chronic diseases like asthma or HIV. It is just a massive, massive strain on our healthcare system.
But obviously, the human cost is even more devastating. Back in 2010, prescription opioids were involved in 16,651 overdose deaths in the U.S. At the time, that number far exceeded the combined death toll from cocaine and heroin overdoses. And you know what's particularly tragic about that statistic? 82% of those deaths were classified as unintentional. We're looking at a crisis where the vast majority of victims literally never meant to take a fatal dose.
And the core of the problem really comes down to supply. Between 1999 and 2010, as the sheer volume of prescription opioids sold completely skyrocketed, fatal overdoses and admissions for treatment surged right alongside them. In fact, the death rate more than quadrupled. It's a textbook case of an exploding supply driving a severe public health consequence.
So let's move into Section 1, the solution, specifically medication-assisted therapies.
To truly understand how we fix this, we first have to recognize that addiction is a chronic disease. It's much like diabetes or hypertension, right? It requires long-term medical management. Enter medication-assisted therapies, or MATs. These are specific medications used in combination with counseling and behavioral therapies to help patients recover. And the thing is, when they're prescribed properly, they do wonders. They reduce overdose risk, increase treatment retention, and significantly improve a patient's overall quality of life. Plus, they actually reduce engagement in criminal activities and lower the transmission of infectious diseases. Now, medically speaking, we currently have 3 distinct classes of medication to approach this disease. First, you've got agonists, like methadone, which fully activate the brain's opioid receptors to reduce cravings. Then, there are partial agonists, like buprenorphine. These relieve the cravings without producing that same intense high. And finally, antagonists, like naltrexone, which completely block the receptors and interfere with the rewarding effects entirely. So you have a toolkit where each medication is uniquely designed for different patient needs.
And here's the thing. When utilized properly, MATs work incredibly well. For instance, a study looking at heroin overdose deaths in Baltimore between 1995 and 2009 showed that just increasing the availability of methadone and buprenorphine was associated with a roughly 50% drop in fatal overdoses. 50%! It's a massive success story. Yet, here is the tragic paradox of it all. Out of the 2.5 million Americans dependent on opioids in 2012, fewer than 1 million actually received MAT. So we have this life-saving tool, and yet less than half the people who desperately need it are getting access to it.
Which brings us to Section 2, the complication. Let's look at the barriers to care.
So if these medications are absolutely proven to be safe and effective, what is standing in the way? Well, let's tackle a major barrier right off the bat: stigma. There is this pervasive, really harmful misconception among the public, and even among some healthcare providers actually, that MATs merely replace one addiction with another. Because of this profound misunderstanding, a lot of treatment facility managers strongly push for a strict abstinence-only model. And this provider skepticism means that even in places that do offer MATs, only about a third of the patients actually receive them.
But, stigma isn't the only hurdle here. Patients also face an absolute mountain of bureaucratic red tape. Insurance policies use some pretty aggressive gatekeeping tactics. We're talking about strict limits on dosages, initial authorization requirements, and these incredibly frustrating fail-first criteria. Literally, policies that force a patient to try and fail other therapies before MAT is finally approved. Even worse are lifetime medication limits, which actively discourage the exact kind of long-term maintenance proven to prevent relapse.
And just to be clear, this is not exclusively a private insurance problem. Even though public insurance like Medicaid covers buprenorphine and methadone in every single state, managed care organizations operating within those systems often apply these exact same bureaucratic hurdles. Most commercial plans severely restrict in-network access, and very few will cover the newer depot injection formulations of naltrexone. So the whole system is fundamentally bottlenecking critical care.
All right, moving on to Section 3, the resolution. Let's explore the policies for a path forward.
So how do we actually fix this mess? Well, federal agencies are finally realizing they need to aggressively dismantle these barriers. A really major step forward came through the Affordable Care Act, which essentially builds upon the existing Mental Health Parity and Addiction Equity Act. Legally, what this does is ensure that insurance plans must offer the exact same level of benefits for substance use disorders as they do for general medical treatments, meaning millions of high-risk Americans finally gain insurance coverage for MATs. It's a real game changer.
Across the board, the Department of Health and Human Services is coordinating a massive counterattack. We're seeing agencies fund incredibly practical things, like user-friendly nasal delivery systems for naloxone. They're rolling out opioid overdose toolkits for first responders, empowering state programs to flag shady prescribing norms, and enhancing Medicaid benefit designs. It's a comprehensive, multi-agency effort tackling the issue from all angles.
Meanwhile, the FDA really has to act further upstream, basically before drugs even hit the market. The agency needs to require that all new prescription opioids meet basic abuse deterrence standards. Now, recently, they actually declined to apply this standard to a drug called Zyhodro, arguing that deterrents have minimal impact. But the data shows even modest safeguards absolutely work. We simply cannot allow easily abused drugs to needlessly fill perceived voids in the market.
And all of this brings us back to the most critical takeaway from our source material. The core driver of this fatal epidemic is the underlying substance use disorder itself. You simply cannot arrest this crisis without dramatically expanding access to addiction treatment services, and specifically, medication-assisted therapies. It is the essential foundation. Without it, all these other systemic changes we talked about just won't be enough to turn the tide.
So, as we wrap up this explainer, I want to leave you with this final thought to chew on. As our policymakers, our insurance providers, and our entire healthcare system evolves, how do we perfectly balance the very real, compassionate need to treat chronic pain with the urgent life-or-death necessity of preventing a devastating addiction epidemic? It's an incredibly complex tightrope to walk, for sure. But understanding the medical realities of MATs is the first critical step forward. Thanks for joining me today, and keep asking the right questions.